So let's start with Rita. She's a 54-year-old Hispanic female diagnosed with type 2 diabetes 4 years early. So she hasn't had it very long. She works as a housekeeper at a local hotel. She's married with grown children and grandchildren. She walks for exercise 3 days a week for about 20 minutes each. She wants to lose some weight. She's previously been to a dietitian, so someone did send her. She monitors her glucoses at home 3 to 4 days a week in the morning with an average of fasting glucose of about 157. A1C 4 months ago was 7.9, so she hasn't been back for 4 months. She's got a family history for heart failure in her father, diabetes, breast cancer in the mother. She's got benign hypertension, hyperlipidemia, mild depression, and gout. You know, pretty common patient, right? Not all that complicated. She's on Metformin, Pioglitazone, Lisinopril, hydrochlorothiazide, Allopurinol, Sertraline, and Atorvastatin. Okay, she's 5'2", she's got a BMI of 30, blood pressure 128/74, hemoglobin A1C now is up to 8.1, so she's worse under control in the last 4 months. She's got an LDL cholesterol of 113, HDL at 34, triglycerides at 187. That's her fasting glucose when she comes to see you. And for the purpose of this case, I left out renal dysfunction. She's got normal renal function. No microalbuminuria, normal renal function, normal electrolytes, normal uric acid. Okay? Pretty standard patient. So the question becomes, what else would you like to know about her? You're taking a history. What would you like to know? Is she compliant with her meds? Adherence is huge. So is she taking the Pioglitazone, or did she wake up one night and read the 1-800-BAD-DRUG thing and she decided to stop it on her own? Maybe y'all are having that happen when they come into your office. I said, we used to practice evidence-based medicine. I think the first 5 minutes of every office visit is media-based medicine now, and it's trying to talk them off the scare. All right, we want to know if she's taking her medicines. Great. For the purposes of this talk, let's say she is, and then she's adherent. Diet. Great. What do you want to know about her diet? Carbohydrate intake. Trans fats. Great. What about her exercise regimen? She's walking 20 minutes 3 times a week. You don't believe her? She is going up and down the hallway of the hotel. What do you think about 20 minutes 3 times a week? It's a start, right? The biggest problem I have with patients is they don't understand how many calories they're burning. They feel like 20 minutes 3 days a week is a lot. And it's good, it's a nice start, but it's not a huge caloric burn, right? This is not someone who's training for a triathlon. And so sometimes their balance of how much calories in a meal versus how much I'm burning is really off when you talk to them. Anything else you want to know about Rita? How about economic status, insurability? She got good insurance from the hotel? Can she afford it? Everything she's on is generic. So when you look at that, you go, Of course, you know, this is sort of different because you do know Rita. She is your patient. You would already know this information. Anything else you'd like to know about her? Education. How capable is she of doing something complex? What else would you know, great. Does she smoke? For the purposes I didn't put up, but no, she doesn't. For the purposes of this, she does not smoke. Okay? All right, those are all great. So let's see. A1C goals. We talked about therapy. What do you think? What's a good A1C goal for Rita? 6.5. 6.5. How many people agree with that? Less than 7? We can have a healthy debate and everybody's right. And this is the same thing the American Diabetes Association says. Now, if you put her on something and she did it safely and she got her A1C to 6.1, would you back off on the therapy? No. Remember the people that were worried about the increased mortality, people we drove below 6 with hypoglycemia, so you don't have any hypoglycemic agents on board. You know, you shouldn't have to worry about this. So I think everybody's in general agreement. She's only 54 years old. She's got a long life in front of her. She's only had this disease 4 years.
If she was on some kind of urea and she got down to 6.1, would you be concerned?
You might, and you want to ask about sulfur, you know, and when we talk about therapy, let's talk about that. Yes, you would. The question was, if she were on sulfonylurea and you got her to 6.1, would you be concerned? Yes. Any other information you want to know before making a decision about additional therapies? Is she checking her blood glucose? She checks them about, I think it was like 3 or 4 days a week, something like that. What are her numbers? When we go back, her average fasting glucose was about 157. So let's talk about this. This is your patient. She's sitting right in front of you. Let's say you have a hemoglobin A1C back. Now, my A1Cs come back the next day, and I pick up the phone and call them, or we talk to them. Or if we know that their glucoses are up, we'll make decisions. I don't do point of care A1C testing. My endocrinology colleagues right down the hallway do. I don't know about you guys, but let's say you've got all this information in front of you. What's your next step? What do you want to treat? You want to get her glucose down? Okay. All right, I'm going to assume for this that she has insurance. She's not a wealthy woman, but she does have insurance. What's your next drug of choice for her? DPP-4 inhibitor. How many people think that way?
It's costly.
It's costly. That is right. It is expensive. How many of you have the $10 copay cards with multiple pharmaceutical companies that give them? Okay.
Lisinopril.
And glimepiride, you've got a thing for sulfonylureas here. Okay? So let's talk about DPP-4 inhibitors. How many of them are there on the market? 4. Allopurinol being the newest one, sitagliptin, saxagliptin, and linagliptin. What can you expect from efficacy in A1C lowering with a DPP-4 inhibitor in general? 0.9, 0.8. Most of the studies are going to say 0.9 is really, really good from a DPP-4. More like 0.7, 0.8 is what you can expect. Which is the most efficacious DPP-4 inhibitor? Which one has the most potency? Anyone? They are just absolutely exactly equal in every phase 3 clinical trial. It does not matter. The only difference in DPP-4 inhibitors is linagliptin, which is an Eli Lilly Boehringer Ingelheim product, and that's because it is fecally excreted, so it's 5 milligrams regardless of renal failure or anything else. The others you have to adjust for a lower GFR. But from an efficacy standpoint, she's got a normal GFR, it makes no difference. So how do you make a decision about which DPP-4 inhibitor? Samples? Formulary? Okay. A DPP-4 inhibitor is a very reasonable choice here. Do you expect to get her below 7% or anywhere close to 6.5 with just a DPP-4 inhibitor here? Well, you're going to get about 0.7, 0.8, so if she's at 8.1, you're going to get her to 7.3. 7.2 if it's really good, if she has one of those wow 1.0 reductions. What else do we want to do? I heard somebody say something about diet. What if you gave her a DPP-4 inhibitor and you sent her to a dietitian? And maybe you said, look, you've got to intensify your exercise, right? We've got to get back, we've got to get some of this weight down. You got a BMI of 30, so you technically are right on the edge of the obese category. All right, any other suggestions on medicines?
You could take away the thiazide and use, if she could afford it, a higher, like an ARB, like the dial, and those are your some insulin resistance.
Yeah, so the argument was get rid of the thiazide diuretics. His point is a good one. Now, we've not used a lot of ACEs and ARBs ever since that paper came out, but you could increase the lisinopril, or you could add an ARB instead of that. The idea that maybe the thiazide diuretic is contributing a little bit, it's a good thought. Usually that's a 0.1 or 0.2 sort of thing, but you know, everybody's different with thiazide diuretics, so it might be a reasonable choice.
Yeah, I agree with the thiazide because it may increase the uric acid too. It may aggravate the gout.
So if you didn't hear him, he said it might aggravate the gout, it may increase the uric acid. Does she need the allopurinol if she's off the thiazide? Good questions. Good questions. All right. Anybody else? So I heard glimepiride. Why glimepiride, not glyburide?
Less hypoglycemia.
Less hypoglycemia. It's a little longer release. There is less hypoglycemia with glimepiride, but it's certainly not zero, is it?
What PCP?
She's on TZD.
Oh,
She's on pioglitazone.
Oh, yeah.
And she's on a moderate dose. As you go up on the TZDs, you increase weight gain.
Yeah, so she wants to lose weight, which would make it more compliant with GLP-1.
She wants to lose weight, so GLP-1 agonist. How many of you are familiar with using GLP-1 agonists and using them a lot? Smattering. Great drugs. 3 on the market right now. Exenatide BID, which is the original Byetta. There's exenatide once weekly, which is a formulation you have to mix up once a week. And then there's liraglutide, which is a once a day. In Europe, there's lixexenatide, which will be coming to the United States, and the Sanofi just withdrew its submission to the FDA because they're going to have cardiovascular outcomes data coming along. So that'll come. There's albiglutide that's coming from GlaxoSmithKline. So you're going to be seeing more GLP-1 agonists. What's the side effect of GLP-1 agonists? Pancreatitis, do you think? nausea is the number one. All the data on pancreatitis is really a lot of noise in the wind. There's really not been any evidence. So if you look at the label warning, it says may be associated with pancreatitis, but type 2 diabetes is associated with pancreatitis. Most people think it's not. I don't want to get into the pancreatic cancer thing. I'm too close to that subject in the ADA. Just let me tell you, the evidence is terrible for pancreatic cancer. So nausea, cost, it's an injection, right, versus an oral. But what kind of efficacy can you expect from a GLP-1 agonist? Over 1. If you look at exenatide twice a day, 0.9, 0.1, they did a head-to-head trial with liraglutide and exenatide once weekly in the LEAD 6 trial, 1.5 for liraglutide, 1.3 for exenatide once weekly, but exenatide once weekly has other phase 3 trials where it's gotten up to 1.6, 1.7 reductions. Very potent, good drugs. Would you give it a go with it? Probably, if she can tolerate it, yeah.
I guess this is an agent mostly that would control the prandial blood sugar because metformin normally controls the prandial, less the postprandial.
Right.
And actually will control both the pre and postprandial. And DPP-4 will control the postprandial.
So his point was that sulfonylurea will control the postprandial, DPP-4 will control the postprandial. The newer, longer-acting agents have less nausea, but they have less postprandial control and more fasting control. So the once-a-week liraglutide, the once-a-week the once-a-day liraglutide, once-a-week exenatide are going to have some fasting effects too, whereas the old exenatide BID is purely a postprandial drug, but because of that peaking twice a day, it has a lot more nausea associated with it. Okay? So GLP-1, sulfonylurea, DPP-4 inhibitor. Anybody want to dip their toe in the SGLT2 water? One on the market, Janssen Pharmaceuticals, canagliflozin. In Europe, dapagliflozin and empagliflozin from Boehringer Ingelheim is right around the corner with a PDUFA date probably in March of next year. Okay? These drugs cause an osmotic diuresis. They inhibit the SGLT2 transport that's responsible for reabsorbing glucose from the proximal tubule. You pee and urinate more glucose out. So the average weight loss is 4%. 5%. The extra urination accounts for about 1 void a day. If you've got too much glucose in the urine, the thought was that maybe we're going to have too much urinary tract infections. Really, urinary tract infections isn't the big thing. The big thing is mycotic infections, balanitis in the male and then vulvovaginitis in the female. If you get vulvovaginitis or balanitis once with an SGLT2 inhibitor, you are unlikely to get it a second time. Not zero, but it's unlikely. Most people just get it once. Okay? Efficacy, 1.0, 1.1, good agents. And if you look at the 2-year data from canagliflozin, you lose the weight about 4 or 5%, and here you are at 52 weeks, and here you are at 104 weeks. So, an option that's going to be on that was not on this protocol. So I think we've explored a lot of reasonable options. What about basal insulin here? Basal insulin. Okay, it might be a choice. She doesn't want to gain weight.
Might get a lot of edema.
Might get more edema with TZD, absolutely. The other thing with a TZD, we got to be careful in women. We're trying to figure out what's a decent bone density to use a TZD in because there's about an 8% risk of long bone fractures.
In history CHF.
CHF? What's that?
In history CHF.
In a history of CHF, yeah. If you've got a patient with congestive failure, do not use a TZD. But they're still a good medicine, and they really treat a core defect that nothing really gets to is that insulin resistance at the tissue level. So I think out of those 4, probably this isn't first start with basal insulin. I think all of those are reasonable. If you have a DPP-4 inhibitor on board, though, you may need extra punch. You may need to make her aware that you're going to do this, she needs to do this. I mean, you know, you're going to have to do something because you're not going to get to a goal of less than 7, unless you just happen to be a very robust responder with just a DPP-4 inhibitor.
She would have had a coronary sales test.
Right.
What would you expect if you were starting the process to come to reasonable numbers?
Yes. If you had an A1C of 10, would you expect Victoza or liraglutide to give you reasonable numbers? What do we know about these agents at higher A1Cs? It's Just like blood pressure, right? The bigger they are, the higher they fall. So when you got an A1C of 7.8, 7.9, you get this drop. When you're up at 10, you get big, robust drops. You can even get 2% drops. Don't think you're going to get from 10% to 7 with a GLP-1. And if you've got somebody with an A1C of 10 and they're adherent, her question right here, and they really are taking their medicine, you got somebody who's getting close to being very glucose toxic. Okay? So then you are talking about insulin. All right? So I think these are all reasonable. There's no right or wrong answer. What can she afford? Do you have coupon cards? Do you have samples? What's she willing to do? Is she willing to do an injection? How do y'all handle injection phobia? Let me just get that out there in your office.
Even the first shot I saw.
Show it to them. What do you do when you get that first shot? What do they always say?
It doesn't hurt at all.
Is that all it is? Right. I mean, they always do. Had a lady come in, took Metformin, new diagnosis, and I said, we're going to start you on Metformin. She gave me that big, huge sigh of release. At least it's not insulin, it's not an injection. I stopped what I was doing. I got an insulin pen needle. I gave her first sham injection. And she goes, why are we doing this? I said, because I'm not spending the next 8 years of avoidance behavior if you need insulin. There are also GLP-1 agonists that may be injections. Let's get past this big monster right now so that we don't have this battle and you don't miss your follow-up appointments because you know you're about to start insulin and that kind of thing. So in the interest of time, everything here is reasonable. What about her LDL goal? She's going to need to intensify her Atorvastatin, isn't she? What about triglycerides and HDL? Are you going to wander in there? Give her some time, wait and see. We have very little evidence that treating this right now, and look, I'm not a lipidologist, and I don't want to get in arguments with a lipidologist. They are disciples, they love that. But we don't have any long-term trials that tell us that's going to work. The only thing we have is the Accord trial that said, in that same one that had the mortality, if you treat somebody with a phenofibrate who has an HDL of 34 or less and a triglycerides of 220 or 30 or greater, you do get some reduction. What was interesting is the phenofibrate reduced retinopathy. That should improve the retinopathy. So I think you're working on her glycemic goals, you're working on this, you're going to work on this. Blood pressure is good, you're going to work on diet, activity. And we talked about this. And I think it's also important that we talk about cultural sensitivity. I mean, Hispanic population, African American population, Asian Pacific Islander population, all of them have different cultural ways of eating. And you have to be sensitive to that. You have to get to where they live. It's not enough to say you need to be, using olive oil and pan searing your, halibut every night, if that's not what they do. And then we talked a lot about this. Exercise prescription. If you do want to get her to increase her exercise, studies have shown, be specific. Write a prescription for it. I want you to walk 30 minutes, 5 days a week. Take 2 days off, you pick the 5 days. And interestingly enough, if you can get anybody to do resistance training, the hypoglycemic effect of resistance training lasts longer than the aerobic